Hello everybody, welcome to our latest Queen Elizabeth Scholarship webinar. We're coming to you from the McMaster Health Forum at McMaster University in Hamilton, Ontario. Quick agenda for today's events. I will talk to you about the McMaster Health Forum and our scholarship program here through the Queen Elizabeth Scholarship Program, and then I will introduce you to our presenter, who is Matthew, who did a very interesting scholarship period with internships in both London and South Africa. The McMaster Health Forum is the leading hub for improving health outcomes through collective problem solving. We aim to harness information, convene stakeholders, and prepare action-oriented leaders to act as agents of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rideau Hall Foundation, Community Foundations of Canada, Universities Canada, and Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The version of the Queen Elizabeth Scholarship Program that is run here at the Forum is on strengthening health systems. Our scholars will contribute to strengthening health systems and become part of our large and growing network of health system leaders. We have had 2 cohorts of scholars so far. Our first cohort, they're all listed here. They've all done webinars, so feel free to check our YouTube channel to see them all. We had 13 in total from our first cohort, and we are currently in the midst of doing the webinars from our second cohort, of which Matthew is one. And then we will have our third cohort going abroad next year in 2018. Our presenter today is Matthew. Matthew is an undergraduate student in the Bachelor of Health Sciences program at McMaster. He has an interest in the universal dissemination and practical application of research, particularly as it pertains to healthcare management. The goals of his internship was to gain insight into the localization of healthcare policies and document how provision of care reacts to healthcare innovation. Matthew's internship was divided between England and South Africa, which made his relatively unique within our scholarship program. So Matthew, without further ado, I'm going to turn it over to you and enjoy.
Thanks so much, James. So thank you for having me, and thank you everyone for coming, both online and in the forum. So my presentation is just going to be around 30 minutes, talking about my experiences in the UK and Cape Town and the lessons I learned throughout. Alrighty, so first off, my itinerary. My QES spanned 2 different countries, which is relatively unique. First in the United Kingdom, and then on to South Africa. Originally, I just wanted to go to Cape Town. I was really interested in their health system and how things worked there. I was also very interested in the dissemination of research evidence or knowledge translation. So the knowledge translation unit was a very natural, organic fit for me. Upon discussing with the administrators and directors there how an internship could be completed, the director mentioned that the unit collaborated often with the BMJ, the British Medical Journal, based in London, England. And so she suggested that perhaps I split my internship across England and South Africa, and I thought that was a fantastic idea. Not only would this allow me to explore 2 countries that I've never visited before in my entire life, it would also allow me to see health systems from 2 diverse, distinct perspectives. So there's lots of flying. I'm very comfortable with airports now, but it was definitely worth it. All right, so my internship focused on clinical decision support tools. These are guides that provide clinical point-of-care guidance, assistance for medical professionals everywhere across the world. And as I said, the first half of my internship was at the BMJ, and they produced a clinical decision support tool named BMJ Best Practice. The next place where I headed off to was the Knowledge Translation Unit at the University of Cape Town Lung Institute, and their clinical decision support tool is called Pact, or the Practical Approach to Care Kit. So throughout this webinar, I'll be describing both of these institutions, as well as the clinical decision support tools that they publish, and my roles within each organization. So I spent the first section of my Queen Elizabeth Scholarship working at the BMJ. So most people think BMJ is the journal. BMJ is actually an overarching company brand that oversees many different aspects, of which the BMJ is the most popular and most prominent. The BMJ is the world's oldest and one of the most prestigious medical journals. And BMJ itself also carries BMJ Best Practice, which is the clinical decision tool that I was working on, BMJ Clinical Evidence, which is the clinical evidence database that BMJ Best Practice uses, and BMJ Learning, which is an educational suite for medical students and medical professionals. So outside of medical publication, BMJ also has a strong commitment to global health, and they've accomplished this by partnering with strategic partnerships all across the world, and one of these happened to include the Knowledge Translation Unit. So my time at the BMJ was a fantastic opportunity for me. As a scholar and as a curious learner, it was one of the best possible learning experiences that I could have been in. The BMJ is a large organization, and it is actually based within the British Medical Association. So that in itself is an interesting dichotomy to see. On one half of the building, you have all the policymakers really working at the forefront of policy decision making, and on the other hand, you have the British Medical Journal doing something completely different, but still quite tied into policy making. So at the BMJ, I had the opportunity to work with a number of different units. At the Knowledge Translation Unit, it was more segmented and cemented. I had projects that I was assigned, that I went into every day and I worked on, and that was fantastic. But at the BMJ, I had the opportunity to explore and work on many different things. So for example, I helped at the BMJ Collaboration Lab, and this is a research unit in the BMJ that focuses explicitly on ensuring that the innovations that the BMJ is developing is useful and oriented towards patients and consumers and stakeholders. So as I assisted with user experience, user interface, so I get to try out all these gadgets that the BMJ had and give my feedback and suggestions, and that was so much fun. And I think they valued my opinion, especially as an undergraduate student, which I think was a rarity in that building. I also got the opportunity to help with strategy and development with BMJ Best Practice directors. BMJ Best Practice undergoes updates all the time, and they're constantly adding and trying out new features, which I think is a great thing, and also provide an opportunity for me as a student to give input and feedback and suggestions into ways that BMJ Best Practice could grow and continue to assist clinicians all over the world. I also helped with copy editing at BMJ Best Practice, just making sure that things make sense, are clear, are grammatically correct. I assisted with research dissemination with a series of publications called BMJ Rapid Recommendations. I identified the most salient and most impactful places that we could give this research to in order to ensure that this clinically relevant, very important research could reach the people that it needs to get to. I had the opportunity to meet with Dr. Fiona Godley, the editor-in-chief of the BMJ. She is an inspiration to me, and we had the opportunity to discuss about the political atmosphere of publication and academia, and it was a lot of fun, and I learned a lot. I also had the opportunity to shadow in BMJ editorial meetings to hear exactly what academic administrators and editorial journalists value in publications, and that was a really interesting session for me. So this is a screenshot of BMJ Best Practice. It's accessible all over the world. People in many different countries, including Canada, use it. It's very intuitive, so you can search up the condition or symptom that you'd like to see, and it's split into very intuitive highlights, theory, prevention, diagnosis, management, follow-up resources. So this is meant for use before, during, or after a clinical consultation to brief up your knowledge on a specific segment of the consultation or to ensure that you provided the correct information. It can be used for anything. And this is the second half of the page here. It's just a quick summary of important things that one would need during a point-of-care clinical consultation, history and exam, diagnostic intervention, step-by-step management. It's all very practical. So in London, I also had the opportunity outside of the BMJ to explore a little bit. One of the highlights for me was attending the International Forum on Quality and Safety, of which BMJ is a co-sponsor. I had the opportunity to hear a lot about how different stakeholders and innovators had ideas about strengthening health systems, especially about the importance of including patient voices in improving healthcare quality. It was also a great opportunity to network and meet different people in different fields from all different countries. One interesting thing is the closing keynote was Commander Chris Hadfield, who's been an inspiration of mine, which was absolutely amazing. So outside of the International Quality Forum, I really enjoyed London culture just as a student and as a tourist, I suppose. It's very diverse, very busy, and I suppose in those ways it reminded me of Toronto back home. One interesting experience in London that taught me a lot as a student and as a human, I suppose, was locking myself outside of my room. Quite embarrassing. The door to my flat was the type that locked automatically, and I accidentally left my keys in the room. At first, I was frustrated with myself, and all I had was my phone and 5% battery in my wallet. But I made my way to the local inn, came to my wits, bought a phone adapter, slept there, contacted my landlord the next day, and all was well. It was a great experience, learned a lot in London, and had an absolutely fantastic time. So after London, I made my way to the Knowledge Translation Unit, which is the BMJ's partner institution in the University of Cape Town. So there's two pictures here. The one on the left is the lobby, and the one on the right is just outside of the Research Institute, and as you can see, it's an absolutely beautiful place to work and study. That's one of the things that impressed me most about Cape Town, the way in which nature and the rest of the world just seamlessly integrated. Like that view of Table Mountain, which is one of the most beautiful places to be in Cape Town, in my opinion, was just fantastic. And so their mission was to improve the quality of primary health care for underserved communities through pragmatic research, evidence-based implementation, evaluation, and engagement of health systems, their planners, and providers. So that, shortened, is to bridge the gap between what we know and what we do. So as I mentioned before, one of the reasons why I wanted to attend the University of Cape Town in South Africa is because of their healthcare system. So if you can see on this chart on the left, public sector spending has remained relatively stable in South Africa, but there's been a marked increase in the private sector for expenditure per head per year, and this is only till 2006. It's continued to rise all the way up to 2012. And this, as you can imagine, presents a problem. If you see the pie chart on the right-hand side, 43% of financing was spent on public services that serviced 68% of the population. 44% of total healthcare financing was spent on private insurance, which financed 16% of the population. And that's only in 2012. Things have gotten much worse. So as you can see, South Africa operates on a tiered healthcare system in which there's a public and there's a private sector. And so this private sector is attracting 80% of clinicians to work in this space, to provide care for only 16% of the population. This leaves the public sector to be underserviced and overstressed and affects the quality of health outcomes and health interventions for the majority of South Africans. So I was really interested in seeing how healthcare innovations like the one developed by KTU could provide at least a part of the solution to this problem. So the KTU develops the Practical Approach to Care Kit, and this is the project that I spent most of my Queen Elizabeth Scholarship time working on. So it's a clinical decision support tool developed by the KTU, and it was initially produced only to combat tuberculosis and HIV and AIDS, because those were, at the time, and still, issues that South Africa really had to deal with. However, the success of that program launched the development of Pact, which covers not just those two conditions, but also 40 common presenting symptoms and 20 chronic conditions and 101 pages. It's quite compact. You can bring it everywhere, and it's very useful. It has a proven ability to modestly improve health outcomes in 4 pragmatic randomized control trials conducted in South Africa. And not only does it have the ability to improve health outcomes, it also has the ability to strengthen the delivery of health and assist with organization and implementation of other health strategies. So this is just a quick breakdown of the pillars of the Pact program. So the Pact program has 4 main aspects that build it up. The first is the guide, the physical clinical decision tool itself. And as I explained, it aims to guide the clinician to assess the patient's symptoms, make a diagnosis, and devise a management plan. The second pillar of the Pact program is training. So it uses a cascade model. As you can see, it starts with one trainer at the Knowledge Translation Unit, and that goes to other coordinators, and that goes to trainers, and that goes to faculty staff. And this allows training to be efficient, as opposed to going to each and every hospital or each and every nurse uses Pact, it's more efficient this way, to train people to train other people. And it's been very successful. The methodology for training is interactive, and it's a case-based plan in which training is done through examples of real-life situations over 4 modules: communicable diseases, non-communicable diseases, women's health, and mental health. Third pillar is systems interventions. So by including inside the Pact guide referral pathways and suggestions about patient's flow and prescriber levels, I'll explain exactly what each of these means later and how I assisted with them. It really allows for strengthening of the entire health system, not just assisting with the provision of individual care. And the fourth pillar of the Pact program is monitoring and evaluation. So conducting audits and reports and interviews and focus groups to engage with end users to see how Pact can be updated is an essential part of the program. And this is just an example of a page that can be found in Pact. It happens to be about dementia, one of the chronic conditions. And so it takes a standardized approach to routine care in assessing, advising, and then treating. It's very straightforward. All pages are formatted the same way to ensure that nurses and clinicians are able to find the information they need very quickly. And a neat feature is the coloring of the drugs. So any medication put inside Pact is clearly labeled with different colors, and that color indicates what level of prescription, what level of clearance that must be needed in order to prescribe. And this really facilitates task shifting and task sharing to allow nurses, to empower nurses to do more. So one of my major responsibilities was assisting with evidence updating. So because, as I mentioned, the Pact guide covers so many conditions and symptoms, it's quite difficult and quite a large task to ensure that the guide is consistently updated. So we take it from a few main sources. The first is the Western Cape government, for the South African version of Pact, that is, to learn about local policy and referral pathways that are embedded in the municipality or in the province. Then we take from the WHO, their guidance, and we also take from the BMJ Best Practice, which in itself takes from multiple places. So the reason for combining this local and global evidence sources to ensure that policies are locally adapted and evidence-informed. We also conduct these evidence updates on weekly updates for some sources and monthly updates for other sources to ensure that the evidence base is always up to date. Another responsibility I had was localizing evidence. So there's no real, it's difficult to apply all global best practices to every area in the world. It's just not possible because there's so many local policies that specify that there should be certain ways to prescribe medication or certain prescriber levels or even certain different names for the medication all in itself. So what I helped with was aligning global evidence bases to local policy. So one example of this is the South African adaptation of Pact is called Primary Care 101, and actually recently had a name change again it's called Adult Primary Care, or APC, and it's managed by the South African Department of Health. So Primary Care 101 allows facilities to adhere to the Ideal Clinic Initiative. The Ideal Clinic Initiative is a new policy that the South African government has been championing. It's basically a checklist that incentivizes hospitals and clinics to become ideal by achieving these health system strengthening goals. So what I did was I ensured that having Pact would allow local clinics and hospitals to be considered ideal by ensuring that Pact's South Africa recommendations were aligned with government priorities. So I also had the opportunity to work on some other projects outside of Pact. The first was an electronic adaptation study that I worked on. So I was writing and currently still writing a manuscript on the feasibility of adapting clinical decision support tools into under-resourced health systems as an electronic version. So what we did is we trialed Pact on a tablet. We went to a few pilot areas in South Africa, and we conducted a mixed method studies in which we analyzed the quantitative metrics that some of the software picked up as nurses were using EPAC, as we call it. We conducted focus groups and interviews with the nurses. Another project that I worked on was assisting with the scoping review of drug policy reform. So I helped synthesize some literature for best practices regarding seizure treatment. That involved searching through some great literature for recommendations to see what different jurisdictions were doing in regards to seizure treatment. Another thing that I helped with was the training and implementation of Pact. Although I definitely learned a lot more through this than I gave back. So in order to practically spread Pact effectively across large populations, this cascade method that I briefly talked about had to be implemented. So I had the opportunity to actually accompany an external trainer to some of the rural hospitals outside of Cape Town. So an external trainer and I drove to these communities a few hours away from Cape Town to assist with training the master trainers who would in turn train facility trainers and then facility staff. I helped with setting things up and facilitating discussions, but I learned so much about some of the tacit knowledge that nurses had about the issues and the benefits and just about the South African healthcare system as a whole. I recently had the opportunity to return to Cape Town for the 2017 Global Evidence Summit, which was a fantastic, fantastic opportunity. I had the opportunity to present some of the research I'd been conducting at the satellite session held at the KTU. I also had the opportunity to reconnect with some of the researchers at the KTU about the projects that I'm going to continue to be working on. So in Cape Town, outside of the unit, I spent most of my time hiking. It's a really, really, really beautiful city. On the left, I had the opportunity to meet up with some fellow Queen Elizabeth scholars, actually, from all across Canada. So we had a great time hiking Lion's Head. And we also had the opportunity to hike around other places, such as Wally's Cave. It's a beautiful output, just a small ridge that you can take really nice pictures at. Yeah, so I really enjoyed my time in Cape Town. One thing I learned about Cape Town, or rather I saw, was the vast societal inequities in that city. And that's something I don't think I was quite used to. I understood that apartheid had occurred and that the legacy of those policies was still ingrained in Cape Town, but not to the extent that I think I saw, at least anecdotally. So it was a really impactful trip to Cape Town. Some lessons I learned. First was to go out of your way to meet people and talk to them. You might find a meaningful connection there. And that was with Dr. Godley. She has been a fantastic mentor. I really appreciated the support, and in no way did I expect that the editor-in-chief of the BMJ would be willing to discuss with an intern, a Queen Elizabeth scholar, about health policy and research dissemination. Avoid shortcuts, especially when in unfamiliar mountains. This is harkening back to the time on Lion's Head when my friends and I accidentally got lost. So stick to the path. It's the best way to go all the time. The massive impact of societal inequality on health system strain. So that's what I mentioned about the public versus private inequities in Cape Town's healthcare system as well as in society. The importance of training and evaluation and the implementation of health systems interventions. So when working with Pact, the thing that surprised me the most, I think, was the emphasis on training and implementation. And I suppose after being there, that made so much sense, that even if you have a fantastic health systems innovation that's evidence-based and locally applied, if people are not all on the same page and willing to support you in this journey, then it just won't work out. So I learned a lot about training during this trip. And finally, health systems innovations can and should transcend borders. Before becoming involved with the Pact program, I had no idea that the British Medical Journal was making the effort to connect with the University of Cape Town. The University of Cape Town was leveraging the evidence databases. It's a very symbiotic relationship that I think benefits everybody all around the world, and I think that should happen more. So thank you so much to everybody for tuning in. If you have any questions, please feel free to ask.
Thank you very much, Matthew. We get applause from everyone in the room, so thank you for that very interesting presentation. We have people online, we have people in the room, so I'll give everybody an opportunity to ask questions. If you are online, I'm going to ask that you please use the chat box to type in your questions, and I'll read them out for the sake of the recording. For those of you in the room, I will ask if you have any questions, and I will repeat those questions again online for the sake of the recording. So while everybody's thinking about potential questions to ask, I will ask the first one, as I typically do. So you started, when you started going, talking about South Africa, you pointed out a very, specific health system issue about the disparity and the funding and where the money's going and who's contributing. So the program that you worked on, the BMJ Pact program, how do you see that fitting into potentially alleviating that larger system issue?
Yes, absolutely. Great question, James. So I think the way in which Pact helps relieve some of that pressure on that overstressed health system is by empowering nurses. That's what Pact is about, empowering nurses and community health workers and non-clinicians, basically, because South Africa has a need for more health workers, especially physicians. And Pact, through its ability to empower nurses to provide evidence-based care, essentially allows these frontline health workers to take on more responsibility because they are capable of it. And when I was helping with training, the feedback that we got from nurses was so powerful. In some ways, Pact changed the entire way in which they deliver care. They're able to prescribe now, as opposed to asking a doctor who asked a specialist. They're able to diagnose now, as opposed to, again, asking a doctor and asking a specialist. It streamlines health systems. That's, I think, the benefit of Pact, and that's where I think the benefits will come in relieving pressure on health systems.
Thank you very much. So we have a number of questions online I see pop it up. We'll come to the room in 1 second. I'll do one question online and then we'll come back. So a question from a Queen Elizabeth scholar who was in London, I will point out, what was the biggest difference that you noticed between the health systems in Cape Town and in London, so in England?
Sure. Great question again. Thank you. When I was in London, the bulk of my time was focusing on clinical decision support itself as opposed to the health system. When I was in Cape Town, I was focusing on clinical decision support in the context of that health system. And I think something, I'm still not answering your question, but I will get to it. Something interesting is that in Cape Town, the practical approach to care kit is much more in tune to the needs of a health system through its localization processes and stakeholder engagements in ensuring that it's localized. BMJ Best Practice is much more general, I think. It has the ability to provide information whether you're in Canada or the United States or in London. It doesn't really matter. It's just useful, period. But the practical approach to care kit is much more streamlined. In terms of the biggest difference in terms of health systems in Cape Town and in London, I think is, again, inequity. I don't want to repeat myself, but I think that's the most striking feature that I saw in Cape Town. London just seems much more fair in that sense.
So we have a question from someone in the room, so just say your question and I'll just repeat it for the online folks. So the question has to do with politics in both South Africa and England and how the politics of the world that we currently live in have impacted the systems or what's going on in either of those countries.
Not too much. The politics were fascinating, though, especially in South Africa. So just to answer your question, in London, it didn't impact me at all, the politics of Brexit and whatnot, not at all. In South Africa, there is still not much impact, but I was still very much caught up in it, I suppose. I think it's hard to be a citizen of South Africa and not really be involved with the political atmosphere. One way, and I suppose it did impact me, was through the Ideal Clinic Initiative. That was part of the National Health Insurance Initiative that was recently launched just a few months ago by the Ministry of Health, and that's been lauded as a paradigm shift in South African healthcare system. It's a huge multi-billion-dollar effort to reduce this inequity that I was discussing. So I think that's one way. Yeah.
Thank you. Another question from somebody watching online. Did you find any specific courses or experiences from your undergraduate career that prepared you for your QES research experience?
Thanks a lot, Christy. I think one thing that helped a lot, it's not a course, but the QES preparation with the health forum, they really allowed me to understand not only the research aspect of things, but also the logistical life aspects of things in order to make sure that I make it through all right. In terms of courses, I think the obvious first answer is my health policy course with Dr. Levis. Learning more about health systems, even what a health system is and how the different players within the health system interact with each other, that was really useful for understanding, I think, the context of my work in South Africa. Another course that helped me, I think, was a course called Communications, where we had the opportunity to talk with standardized patients, and that really helped me interact with patients and nurses and researchers, basically people that I wasn't too familiar with, because when you go to this other country, you're thrown into an entirely different environment. Yeah.
Thank you. Any other questions from anybody online or anybody in the room with us? Just going to advance the slide here, the question slide, to the thank you slide. So any other questions? So while I'll give people a chance to think, you worked for an organization that was in more than one country. Was there a difference in how the organization ran things in London as opposed to how they ran things in a place like Cape Town?
Yes, absolutely. And I loved both of it. That was one of the highlights of my experience, seeing the sides of healthcare management from two different pages. The BMJ is a huge organization, internationally renowned, prestigious, always things to do, hustling, bustling, but it's large. And sometimes I think it's hard to feel that you're making a tangible impact. There's so many interesting things to get my hands on, and thankfully for everyone at the BMJ, I was able to do that. But I think there were relatively small contributions, but contributions nonetheless. In the knowledge translation unit, it was a compact unit of researchers, graphic designers, administrators, trainers, clinicians, and everyone was packed together in this one unit. It was just one floor of an institute. And I think that really assisted with the ability to make real change quickly. The agility was outstanding. If I had a graphics question, I would pop in next door. And if I had an administrative question, I would pop in to the secretary. If I had a question about my prenatal scholarship experience, I would go walk into the director's office. So I think there's things to appreciate and value on both sides.
Thank you. And one last call for anybody online or in the room. Oh, we have another one from someone in the room, so go ahead. Yeah, so as a fourth-year undergraduate student now, looking ahead to your future, how do you hope to carry these experiences through to your future endeavors?
Great question. Thank you so much. So I think a super tangible way, this is probably not what you're asking, in which I'm carrying this forward is by working on 2 papers and continuing to work on them with the knowledge translation unit. I'm really interested in the work they're doing about task sharing and how that fits into health policy. So that's real interesting work that I would have never been introduced to without the Queen Elizabeth Scholarship. But I think other ways in which I'll carry this forward, as I mentioned before, my time in Cape Town had a really profound impact on my perceptions towards inequality and how that plays into the healthcare system. So I think in the future, in terms of research interests or pursuing grad school or whatever lies next for me, who knows, I'll definitely keep those lessons in mind.
Thank you very much. So one last call for anybody else in the room or anybody online. I think everybody has gotten what they needed from you, Matthew. That's my sense anyway. So I want to thank you very much for taking the time to do your webinar and your presentation here today. Draw everybody's attention to the slide that's on the screen right now. Just a couple links that I'll point out. The first one is if you're interested in applying for a Queen Elizabeth Scholarship Program, that first link is one that you can go to and find all the information. The second link lists all of the webinars that are currently taking place this term, so please check it out, see who's presenting when and how you can be connected. And the last one is all of our Queen Elizabeth Scholars write a blog for us, and that blog page is that third link, so please visit that blog page and read their blogs and find out the more personal things that they experienced while they were abroad. So thank you very much, Matthew. Thank you everyone for joining us today. For those of you who are here real time and not watching this later on YouTube, we actually have another Queen Elizabeth Scholarship presentation today in just 20 minutes from now. So if you are online and you want to stick around for that, just stay where you are because it's the same webinar, and we'll just continue on at 4 o'clock. Otherwise, thank you very much, and we'll see you soon. Bye-bye.